Dr. Cohen, may I call you Jon?
Absolutely. Thank you.
Thank you so much for being here. Wow, you've had such an interesting career, and I'm always fascinated by people's origin stories. So I want to start from not the very beginning, but when you realized you wanted to be a doctor.
Sure.
Why?
So thank you, and thank you for the opportunity. So I grew up in Queens, and in 5th grade, I won the science fair.
Yay!
And I was.
Do you remember what your project was?
I actually do. It was actually a dissection of a calf's heart, which I presented in this certain fashion.
Well, that was very predictive, wasn't it?
A little bit predictive. And I just loved science. I loved to read when I was growing up, and I think it was from that point forward that I said I really want to be a doctor. So I don't. That's the one event that I can point to in my life early on.
You ended up becoming a vascular surgeon.
Yes.
That cow's heart was really fascinating to you.
Absolutely.
Tell me about what led you to that specialty.
So when you're in training, and surgery training, it's a 5-year surgical training program, which is I did at New York Presbyterian Weill Cornell, where I did meet my wife. We met as residents and got married our 2nd year.
Who's also a surgeon, by the way.
Yes, she's also a breast cancer surgeon.
As is your daughter and son-in-law.
Thank you for that, yes. I definitely wanted to be a surgeon for a long, long time. I don't know when that happened. I was quite honestly probably influenced by MASH, the TV program.
Really?
Alan, there's no question that Hawkeye Pierce was a hero of mine. I think
that is so funny.
I think it had some influence on me. And so I trained for 5 years of surgery and then trained for vascular surgery for post-residency up at the Brigham and Women's Hospital at Harvard. Then came back to New York and then have been here ever since.
I have a dumb question, and I should know this because I am really interested in medicine and science. I think partly because of my husband's diagnosis of colon cancer, I had to learn very quickly about cancer. And my brother-in-law was the head of cardiology at the University of Virginia, my alma mater. And so I know a little bit about heart stuff, but I don't actually understand what a vascular surgeon does. Is that embarrassing?
No. It's not at all embarrassing. I'm not surprised because most people don't. So the difference is between cardiac surgery and vascular surgery is vascular surgeons operate in all blood vessels except for the heart. So it's all the big and small blood vessels, the carotid arteries that supply blood to the brain, aortas that supply blood to the rest of the body. And so all of those blood vessels have certain abnormalities during people's lifespan. And what we do as vascular surgeons is fix those abnormalities, whether it could be fixing the blood vessel to the brain, the carotid artery, whether it's fixing blood vessels to your legs so people don't lose their limbs, or whether it's fixing the aorta for something called aortic aneurysms that can burst. So that's the specialty of vascular surgery. So that's what I did for almost 20 years.
So you were less interested in the cow's heart and more interested in what made that heart tick?
More about how you got the blood there and how the blood left there. That's right. And the diseases associated with that. So that in and of itself is its own specialty.
So what was your most frequent surgery that you'd perform?
Aortic aneurysms, which are bubbles, which form on very large blood vessels. So the most common surgery I did was aortic aneurysm repairs. And a lot of famous people, including actually Albert Einstein, died of a ruptured aortic aneurysm.
Wow.
So many people much early in the 40s, 50s, and 60s until the techniques were developed to be able to repair them. So that was my most common surgery.
So do you get a warning that you have that problem? Or, I mean, how do you operate on that?
So the aortic aneurysms are a silent killer. You only would know it if you happen to get an ultrasound or a CAT scan and someone discovers it. You can discover it if they get very large on physical exam, but most of them were discovered with people who do not have symptoms. Now the other things other entities I operated on, carotid arteries, which is people frequently have warning signs of a stroke, and people who have leg problems, we knew that they had those problems because either had threatened limb loss or they had pain when they were walking. So there are different types of surgery, but for me personally, it was mostly aortic aneurysm repair.
So after your career as a vascular surgeon, you transitioned to a lot of other roles. You are a man of many hats. You were leading the large-scale COVID-19 testing efforts at BioReference Labs during the pandemic.
Yes.
What was that like?
So I was very fortunate. Yes, I've had a very circuitous path, which is a nice way of describing it.
We haven't even gotten to Talkspace yet.
Right. It's which is a sort of a nice way of saying that I did a lot of things. So BioReference, I was the CEO and executive chairman for about a year when COVID hit, which is just an extraordinary event, as we all remember, or try not to remember at this point. So we were faced, BioReference is about the fourth largest laboratory in the country, and we were faced with the trying to figure out how to make the diagnosis in people and how to get COVID testing. So we did end up being the leader in a lot of the customized solutions. So we ended up testing for the NBA bubble, if you remember.
Right.
We did the exclusive testing for the National Football League, all 256 games to
Wow.
the Super Bowl. We relaunched the cruise industry with Royal Caribbean and eventually was testing out of 10 or 11 ports around the country. And then we were running most of the New York City school testing thousands of children in hundreds of schools every single day. We did the overwhelming majority of school testing for New York City and other school districts. So I had a very unusual experience with a great team of people, and as you know, I ended up writing about what it's like to be a leader during a crisis, which is a very different crisis. So there are crises that happen, and then you have to react. COVID was very different. One of my favorite quotes is COVID is where intuition goes to die, because every time we thought we knew what was going to happen, something different happened, and it's a little bit like being in the field in war, because you never really know what's going to happen the next day. So every day we will wake up and changes would occur. So it's a very different type of management than an event that occurs and then you actually deal with the crisis. So it was an extraordinary personal experience and an extraordinary, really experience for the company.
I'm curious how you feel about all the Monday morning quarterbacking that's taken place as COVID has receded in our consciousness. It has become so politicized, and I think it actually fueled a lot of people politically. Yeah. And, there's this lack of trust in science. There's so many things that are a part of this. But what do you make of it?
I'll stick to diagnostics because that's the industry that I was. I will tell you that the rollout in the COVID vaccine was remarkable in terms of the number of lives that were saved. And there's a lot of people that deserve credit for that. I do think Pfizer and the CEO of Pfizer had an extraordinary role in being able to move the COVID vaccine as quick as they did, and the ability to the administration, the Trump administration at the time, to actually roll it out. Now, having said that, on the diagnostic side, as I sit here today, if God forbid there's a bird flu outbreak or any other, I will tell you, unfortunately, we're still, very, very ill prepared for another pandemic on the diagnostic side. It continues to be an issue relative to can we scale and test millions of people a day, and that discussion still really hasn't happened.
Why do you think, I've done interviews about pandemic preparedness, and it's been ever thus,
Right.
Before the COVID outbreak, we weren't prepared. A lot of people said, well, we've learned a lot and next time we'll be better prepared, but it doesn't ever seem to get traction, this idea of gearing up for the possible.
Yeah. Like you said, it's probably, all political or politicized at this point. I can't tell you why. I just know that having been through it and seeing, what we do or don't have now, we're not really ready for another pandemic on the diagnostic side.
A lot of people, I think, complain about school closings, right?
Right.
And I always think, well, what if a bunch of kids had died, right? And that science is an art, and that people learn, as you said, where intuition goes to die. People were learning in real time about how this virus behaved.
Well, not only learning, but then every time, as I said, that we thought, then you had Delta, then you had Omicron, and then we moved from testing. Remember the lines, people sitting in their cars for hours and hours and hours to sit at a drive-thru to get tested. And then we moved from testing. And at one point we were doing 100,000 tests a day in a lab that had not done one single test in March. And so we scaled for several months to get up to that point. But remember, we moved from COVID testing, from swabbing you, then we moved to testing what's called point of care, where you would go someplace and they test you and you'd wait for 30 minutes. And then we went to home testing, but you had to send your result in. And then we went to testing where people tested themselves. So the evolution of the technology alone was extraordinary. Once we got to where people figured out what they needed. But those changes alone only occurred over maybe 6 or 7 or 8 months. Think about that. We test everybody one way, and then we wake up and say, oh, no, now we have to test people another way. Oh, and now we need to test them another way. We were trying to manage that on a day-to-day basis, and people screaming for the results. Anyway, it was an extraordinary personal experience, I could tell you that.
I bet.
Yeah, it was for 3 years.
Well, I was going to say, was it traumatizing in some ways?
No, I don't. To me, it wasn't traumatizing.
I was going to say, you're a surgeon.
It was very, in some sense, invigorating. It was exciting. That may be not the right adjective, to be in the middle of it, but to be part of it and to help figure it out. It was an amazing personal experience, and for the team of people I had around me. They were unbelievable to be able to pull this off, quite honestly. We did a lot of experimentation, guessing, making decisions, good decisions, bad decisions, moving forward, trying to figure out what was going to work and what wasn't going to work. I mean, we were literally testing hundreds of thousands of people a week in the test that didn't exist in March of 2020.
So you go from being a vascular surgeon to overseeing sort of the diagnostic technology, the evolution of the diagnostic technology for COVID, right?
Right.
And implementing it in very high-risk situations, right? I can't think of a higher-risk situation than a cruise ship, right? Where there was such a huge outbreak early on in the pandemic. How the hell did you become CEO of Talkspace?
Yeah, it's...
Well, first of all, maybe we should explain what Talkspace is. Can you help us with that?
So Talkspace is, we're publicly traded. We've been around 13 years, went public about 3 years ago. So Talkspace right now is a mental health virtual provider. So what you do for Talkspace is if you need mental health therapy, you go online and we have multiple modalities. So you can be treated, a lot of people get treated by video, live video. It's a live video visit. We are, by the way, a fully HIPAA-compliant healthcare organization. We have 6,000 therapists in all 50 states across the country. And what happens, you get matched with a therapist, and the therapist, just like you would go to a therapist to get therapy, mental health stories, does that online video. We also have, which I thought was quite amazing when I got there, Talkspace did most of the original research that you could provide therapy through texting and messaging.
Right.
So
it's called
asynchronous therapy.
Yeah, and asynchronous.
So asynchronous therapy means that if you send a message to your therapist at 3:00 in the morning, she or he's not getting back to you probably till 9 or 10 the next day. So it means that it's not happening. It doesn't have to be instantaneously. That's correct. So that's why it's called asynchronous. So it turns out Talkspace did most of the original research on that to prove that you could actually deliver therapy adequately through texting and messaging and then move to video. From there, and we talk about it, I got there a little over 2 years ago, Talkspace made a big pivot to being in network. So most people's insurance now cover therapy through Talkspace. That's very important. We have 165 million covered lives, soon to be 200 million covered lives, which means when you're looking for therapy now, a good chance you don't have to pay for it, or there's a very small copay or out-of-pocket charge. That's changed the dynamic dramatically for Talkspace, because the number one, I talk about this all the time, the number one barrier to getting healthcare is cost. So now, instead of going for therapy...
And mental health care,
right? Right. And in general health care, the number one issue is cost. So now in mental health, because of a bunch of other issues we could talk about in terms of accessibility and availability, but affordability, cost has been a big issue. So now, if people are looking for therapy, basically the insurance is going to cover it. That's fueled a huge growth in Talkspace in terms of the number of people accessing. So that's what Talkspace is briefly right now.
And I want to talk more, obviously, about a lot of things you raised, but why did this job appeal to you? Right. And no offense, but why are you qualified?
Yeah, so you've asked the same question you've asked is what most of my close friends have asked me also. Like, how in the world is this happening? So first off, total transparency, yes, during medical school, I think I had a week of psychiatry. So I'm not going to tell you that I have any psychiatric background or any qualifications from a physician point of view to be a psychiatrist. And I have a chief medical officer at the company. Her job is to be that physician and that leader. So when I was at BioReference, and prior to that, I was actually a senior executive at Quest Diagnostics, I have a fairly deep background in digital health. So I was always interested when we built a digital health platform and how you get your medical records and how you get results online. And we built a very interesting digital health product when I was at BioReference to be able to go to your home and draw your bloods and get a digital result back. So we built that platform. There was the chairman of the board at Talkspace met me when I was at BioReference and asked me at the time if I would consider coming on the board. So I joined the board of Talkspace first. And then post-COVID, after leaving BioReference, not sure what I was going to do next, they asked me if I would consider coming off the board and taking on the role of CEO of the company. So that's how I ended up there. So I was on the board and then came off to become CEO. And that's a little over 2 years ago.
So it appealed to your interest in digital health, yes, and I guess making healthcare more accessible and affordable.
Yeah, so there were a couple of reasons. One is, which is we should get into, is what we like to say is the mental health time has come. If you had this discussion 10 years ago, we couldn't have this discussion 10 years ago. Now, mental health has become front and center. It's become physical health and mental health, and it's become as important, which it should be, as physical health. So one is mental health time has come. So that was very interesting to me. Two is the market, the total addressable market, meaning the ability to have something that has a big influence and has a very big market is very important, because if you have a solution but nobody wants it, that's not really very great, right? But if you have a solution, which I believe Talkspace had, in a market where 50% of the people coming to Talkspace every week are new to therapy.
What percentage?
50.
Wow.
So you have this incalculable number of people who want it, who need it, and turns out Talkspace has a solution that is scalable, affordable, accessible, and available. So for me, it was a very interesting opportunity. And like you said, I'm certainly not qualified on the psychiatry part or the mental health part. I think that eventually, as a leader, which you see in a lot of different industries, if you learn how to lead, then you can figure it out if you put good people around you. And it's whoever's president of the United States, whatever corporation is CEO, a lot of people walk into those positions with not having industry experience, but they have leadership experience. And there's a big difference between being a successful person and being a leader. Very, very, very different. But anyway, that's why.
I want to talk about the stigma of mental health in a second, but I just like to respond to and have a conversation and respond to what you just said. What do you think makes a good leader? I'm just curious, because I feel like there's a real dearth of leaders, or I think a lot of people look around and say, where are all the incredible leaders in our society?
So part of that is without getting too political, is the reason most people don't run for office as a leader is because of the quote blood sport that the news and the press is. Nobody wants to put their family and everybody else through what most people have to go through if you're going to run for office.
But it's also the Oppo research, just to defend the press for a second.
Yes.
A lot of it is coming from whoever is running against you. Right.
So that, to me, is one of the biggest issues. So back to the issues of, leadership. So I do talk about it during the COVID crisis, and the book is there are a bunch of different attributes that make a person an effective leader, and there's a lot of people talk about it. So without any particular order, first off is, to me, it's very important that you listen to your inner voice. I tell people, I call it the little man sitting on your shoulder. And as a physician, as a surgeon, you need to listen to your gut instincts and what your brain is telling you, and not ignore the obvious. Now, that may seem like, okay, well, that doesn't sound very important, but a lot of people don't. A lot of people don't listen to their inner voice. So that's one. Second is you need to be able to communicate effectively, both in internal communications and external communications. No particular. Third, I best mention, you got to surround yourself with great people, because you can't do everything. And unless you have great people around you who you really trust, incredibly important. You need to read. I know it's but you need to read, and not just about your industry, but I would tell you an enormous number of ideas that come to us or through me is because I read about something that is totally unrelated to what I'm doing and saying, wow, maybe that applies to what we're doing. So becoming knowledgeable reading, I think walking the walk is very important. Meaning you have to be out there. You can't be an armchair surgeon or an armchair leader. You have to be out there. And during COVID, I remember going to visit the cruise line industry. I'd never been on a cruise in my life. And I get very, very seasick. But I went and I walked the ship to figure out how are we going to get people tested before they got on the ship, just to give an example. So you need to walk the walk and really understand what the dynamics are in the field to be able to help lead effectively a bunch of people. I think staying in touch with people is extraordinarily important. I will tell you, our ability to test different places, when we tested for New York State, when we tested for New York City, when we did the majority of testing for a lot of 15 of the counties in New Jersey, it was all because of different people that I had met during my life that I was able to pick up the phone, or they picked up the phone to call me and say, listen, can you help? So those are, I think taking risk is important, or feeling comfortable taking risks. COVID we made a huge amount of decisions during uncertainty. You have to just get comfortable that you're going to make a mistake. So those are just some of the things that make an effective leader during a crisis anyway.
Let's talk about mental health and the stigma that used to surround it. Why is there less of a stigma surrounding mental health today than there was 10 years ago, to your point?
Well, first off, if you look at either Gen Z or millennials, they're so out there talking to people and comfortable discussing their feelings. They grew up in a very different environment than I grew up, and there are still cultural stigma issues. There are definite issues with certain subsegments of the population that just will never talk about it. However, the idea that the younger generations feel much more comfortable now, maybe because it's also because of the phones and cell phones, and they're used to communicating and they're used to talking to people all the time. But it's very, very different. In addition, people are aware now and they're willing to discuss it. So, we may talk about, well, what's happening with seniors, and now talking about seniors and loneliness and isolation. I'll give you a great example. When if you remember Damar Hamlin, he was one who had cardiac arrest during the football team. Remember, we're a football game. What was fascinating is, fortunately he did incredibly well, and they got him off the field, and he's back. But the day after that, I will never forget. I think it was on CNN. One of the player reps, the guys who lead part of the players' unions, got up there and said, "Guys, man up. You need to go talk to people about this. You guys can't just keep your feelings internal. You need to go out there and see somebody and talk about it." The NFL, that never would have happened 10 years ago. That someone would sit on broadcast TV and say to guys, guys, you got to figure out how to deal with your emotions. So the idea that it's out there is very important. I don't know if you know. So our brand ambassador for Talkspace has been Michael Phelps.
Yes, I know Michael.
So he's been amazing. He still is. He's been amazing. And his journey, his mental health journey, actually helped put Talkspace on the map. When he agreed to talk about his mental health journey, and he became a big part of Talkspace and still is, talking about his journey. So I think it's people are now willing to talk about it. And actually it's no longer a stigma to get help.
I think you're right. People are talking about it more. And I think there's just a greater understanding, as you said, about the importance of that mental health is as important as physical health, right?
Yeah. I mean, I've been out there talking about it. I think everybody should have a primary care physician. Actually, I believe everybody should have a therapist. I think everybody should have somebody that they can talk to. It would be really helpful.
Let's talk about the accessibility, because I know there aren't enough therapists out there. Or at least that's what I've read, especially in rural communities, especially in some underserved communities. And I think there is still perhaps more of a stigma in underserved communities.
Sure.
Can you talk about the challenges of providing mental health services to people in those situations?
Sure. So the availability or accessibility, they're linked. So availability is, okay, is there a therapist actually available to take care of you? The other part of that is, are they accessible to you? Can you get to them? It's no good if you have a therapist, but you're 300 miles away and you can't get to them. So the Talkspace solution has solved that issue, because what happens is, by doing virtual, you don't have to leave your house. You don't have to travel. We make it incredibly easy for you to schedule it. And by the way, if you want to get a therapist through Talkspace, we're going to match you with a therapist within 24 hours, and frequently it's several hours. So you could start communicating with your therapist within 24 hours if you match your therapist through Talkspace. So that solution has made it very, very easy for people to get help. So I know we may talk about Teen Space, which is the program we're running in New York City, but I'll jump ahead to some of the data. So we have almost 20,000 kids between the age of 13 and 17 who are on the Talkspace platform. We have a contract with New York City, it's public, to provide Talkspace to 465,000 eligible teenagers between the age of 13 and 17 for free for New York City teenagers. So all you need is your zip code and your date of birth to sign up. So if you think about it, we've had 20,000 teens sign up within the first year. I will tell you, no question, 99% of those kids never would have had therapy before, right? The reason is we've made it, one, affordable, it's free. It's incredibly successful because 90% or greater of the kids are accessing it through their phone. So now what happens? If you look at, we've done the zip code analysis. So where we're reaching into communities of color, underserved communities that never would have access before, because we're meeting kids where they are, which is on their phone. So we've solved the issue. So whether you live in a rural community, as long as you have internet access, you can get therapy through Talkspace.
Are you finding it difficult to have enough therapists to treat the need?
So we do not. We have therapists. We're continually adding to the platform. Part of the reason is because, well, the majority of our therapists are what's called 1099s or part-time. A lot of them are actually stay-at-home moms, or they have a small practice on the side. So let's put aside the video for a second, because video you have to schedule. You know, we like people to do an hour of first intake and then subsequently maybe shorter periods of time. But at least almost 50% of the Talkspace sessions are still done through texting and messaging. The reason that's important is you have an incredible ability to scale when you're texting and messaging all during the day or in the evening or weekends. So our therapy network flexes to a significant degree. So a lot of therapists may take extra hours at night. They may take extra hours during the weekends. They may say, oh, you know what, a week from now I'm going to take a bunch more sessions because I have time availability. So because of the scheduling system is so effective, and because they can make themselves available, we have a lot of ability to flex, because they're not just saying, okay, I could see 8 hours of patients, I could see 8 people, or I could see 16 for a half hour. We have therapists who could be texting and messaging 30 or 40 people at a different time, because it's so easy in terms of how you message people back and forth and have conversations back and forth.
Now, of course, that raises a red flag for me, thinking, gee, if I were a traditional therapist, or I was somebody who wanted therapy, how effective is that? And I know you all have done reams of research on it, but, talk therapy requires talk, or does it?
So it does, but the research is very clear that it's highly, highly effective. So we have outcomes measures. We measure quality. We have a huge number of quality metrics in terms of we measure relative to therapists, their ability to develop to deliver therapy and adequately. But we have measure in some instances every 3 weeks how effective the therapy is in terms of what the outcomes look like. So we know it works. And to the credit of the insurance companies, they figured out it works also, which is why they've put us in network, because it's become it's an important solution for them to be able to provide mental health support as opposed to the standard way that people usually provide it.
There was a time where people were too ashamed to to contact their insurance companies and say, I mean, I've been working for a long time, and I think 10 years ago, people would be worried that their employers would look askance at them, or they wouldn't have enough privacy, and they would be afraid to actually reach out to their insurance company to cover therapy.
So if you ask any HR executive today, tomorrow, what's their number one issue? It's mental health support for their employees. So they have recognized to a very significant degree how important it is for their employees. And we, again, have data. So I will tell you, it's another extraordinary statistic. The average number of days lost to mental health is 28. 28 days a year lost to mental health support for employees. So employers know if they have mental health support, which we do for Talkspace with a significant number of employers, is it improves, first of all, decreases people who are absent, it increases productivity, and it makes the workforce happier. So the impact is hard to measure, but it's enormous.
So those days are over when you wouldn't tell your boss or would be afraid.
So we have, in addition to, I talked about the cover network, we still have a consumer visit, meaning people who still directly come to us to pay for therapy instead of using their insurance. And the reason is there are still some people who say, I'm not sure who I want to know. I'd rather pay for it out of pocket. I'd rather just not have people know. So I don't think that's ever going to go away completely, but it's much less than it was years ago. Much, much less.
So you bring up affordability. How much does it cost, or does it depend? And how much does insurance cover? Yeah. And what about people who don't have insurance?
So the average out-of-pocket cost, if you're covered by your insurer right now, is about $15. The majority of people have no out-of-pocket because we're covered. We're a covered service. Now you're expanding the Medicare coverage, right? So it's December. By the end of this year, we will be in just about all 50 states. It turns out you have to go state by state for Medicare, even though it's national. So we've made a big effort to cover Medicare, elderly adults. And that will launch really January 1st of 2025. The reason being, of course, is 25% of people over the age of 65 have a diagnosable mental health condition, which is usually loneliness and / depression. Almost 40% of people feel socially isolated. So we know that is a very significant issue relative to the older population. So we've launched into Medicare. People have standard Medicare, as you may know, where you get 80% covered and then you have other insurance, or people are in Medicare Advantage programs where there's no out-of-pocket.
Is that a fast-growing population for you all? Because again, those are people, I'm going to be 68 in January, good Lord. And I think that's still a population that might feel less comfortable with therapy or talking about their problems, right? I'm not one of those, by the way.
I wouldn't even say the jury's out. The jury hasn't even been seated, meaning we're just getting into Medicare. We believe that we know it's an enormous need. So we have a whole plan to roll this out in terms of how do we tell people about it? How do we get them comfortable with it? So there's been some questions raised about, are seniors going to use it? So my view is, like the teens, is we need to spend a lot of time educating people and telling them about what they can do. We also have to spend time with their caregivers, which frequently is their children who are taking care of their parents. and getting them come. Frequently, it's the children of the seniors that actually want the support more than the seniors want the support, because they're dealing, they're in between. They're dealing with their kids, and then they're dealing with their parents. So we're about to launch. We'll see how we believe it'll be successful. We know that the need is very high. There's been some question about, will seniors use the technology? My view, we talked about earlier, if you're a grandparent, ask any grandparent. They know how to get onto their phones. They know how to talk to their grandchildren, and they know how to FaceTime them. So I think the technology piece is not of much concern to us. We do have the data on people using technology from, if you're 65 to 70, it's 70 to 80. So there is a fall off after 80 years old in terms of the certain abilities. But we do encourage people when they sign up and use it to find somebody to help them.
And that's going to change as the population ages, because people are becoming more proficient on their phone, and that's not going to change, right, as they get older. You're now focused on the military population as well. Why and how? Okay.
So military, there's 10 million military and dependents. We just got into network with the coverage for the military, which is it's called TRICARE and TriWest. So that's also just being launched. The suicide rate, as you mentioned earlier, is high in the military. The amount of PTSD is obviously very high. It's a little bit different for active military versus their dependents. We're very early on, but we know that there's a significant interest in the military spouses and children of active military that are looking for mental health support. So that's also a work in progress, just launched.
Let's talk about the youth mental health crisis. It's something that I've been very interested in, and it's super concerning, as you well know. I mean, you look at some of the statistics. Teen mental health had already begun worsening prior to the pandemic. By 2021, more than 40% of high schoolers reported feeling persistently sad or hopeless, and experts expect the trend to continue. What is eating the nation's children?
Yeah, so it is a crisis, an unparalleled crisis, and you probably see the Surgeon General report about social media addiction.
And also Jonathan Haidt's book, The Anxious Generation. Right. And it's so funny. When I was at CBS in the early 2000s, I wanted to do something on phone addiction. And they all thought I was crazy. Yeah. But, I thought it was tearing apart families, that people weren't spending time together, that it was taking over people's lives. Anyway, that's me patting myself on the back for being prescient. Yes. But it feels like we have reached a tipping point finally in understanding the negative impact of phone addiction.
Yeah. So you mentioned some of the data. We know that 20 to 25% of teenagers on intake have had suicidal ideation. Which blows me away. I remember seeing the data for the first time. It's just unbelievable to me to think that that's what's happening. So why is the crisis here? The phone issue is unquestionably propelling a lot of this, the social media addiction. So I don't know if you've talked about, but the average number of hours a teenager is on their phone is 8 hours a day, right, on their phone. And of course, it's not just the social media that they're looking at, it's the dangers, right? So you talk about suicide, right? Being aware. It's, of course, the inappropriate content. It's the cyberbullying. It's the issues about being recruited to do something really bad.
And then just old-fashioned self-esteem issues, right? Self-esteem. Where you see people living their best life on social media, and it makes you feel bad about yourself. Or with girls and eating disorders.
Right. And then there's the social media addiction is obviously a huge issue. So it's real. So I I don't predict that you're going to be able to get kids off their phone. I will tell you that having seen this, read about it, see what's going on, I think I told you I have a 7.5 and a 4.5-year-old grandchildren. It's terrifying to me about, what's my daughter and son-in-law going to do about, phones with these kids.
Well, I think people who have kids that age are starting to realize how dangerous they are. By the way, so I have a grandson too who just turned 8 months. And I was thinking, when Ellie is with him, if she's on her phone, she's modeling a certain behavior. So it's not just not giving kids phones until they're 15 or 16. It's not having them as such a ubiquitous force in their lives, right?
So it is difficult. We're not going to certainly solve that. So at Talkspace, we've leaned in on teens, as I said. So we talked about New York City. We just announced Seattle, another 55,000 students. We have Baltimore, and then we have a bunch of other private schools in other districts. So what's become very important for us is because we're actually using their phone to some benefit, which is texting and messaging therapy. We found that it's very, very important and attractive for the student to be able to access it. And so most of them are accessing it actually after school, just, after 4 p.m. Turns out after 4 p.m. on Thursdays is the most popular time. But what's also important is we, in 2019, Talkspace reported on a large language model, AI / ability to actually predict suicide based on a conversation.
That's so fascinating to me. Can you tell me sort of in simple terms how that works?
So what it is we looked at all of the millions of conversations and was able to identify with kids at risk certain words and phrases in the context of the conversation that will alert the therapist of possible self-harm for that person and now teenager, because we've revalidated in teens. So let me describe it this way, because this is the way it's described to me, because I knew nothing about this certainly several months ago. Is some of the things we do is what's called bag of words. So here's the context. If I say to you, look at these 4 words, and I'm going to say a crib, a rattle, a doll, and another toy. That's obvious. And those words all belong together.
Right.
But if I said to you a rattle, a crib, a diaper, and a knife, you would say, well, okay, something's wrong. That's a simplistic way of what's called bag of words. So what the engine does, it looks at the conversation and it is able to actually pick out words and phrases that are key to determining whether or not a person is thinking about self-harm. It's unbelievably fascinating. Now, it doesn't mean the kid.
Is it?
Yeah, so it's 86% accurate, and we've actually dialed it to be more false positive, because what you want to do is have more false positives.
Better
than false
safe
negatives.
than sorry, obviously.
Correct. So we reported this back in 2019. Since we reported, so what happens when you're on a texting and messaging platform on Talkspace? The engine is running in the background. And what it does is it sends an alert to the therapist. And then the therapist decides whether it's real or not real.
That's scary and a big responsibility, isn't it?
Yeah, well, it's like any other, actually it should be. It's like other healthcare alerts. It's like telling your primary care physician, Katie just had her bloods drawn, her potassium is 6. We want to make sure that you've seen that, because that's really dangerous. So there are a lot of alerts that go on in medicine. So what this is, and there may be a reason for it. So the therapist then has the discretion, okay, this is real or it's not real, and then has to decide how to deal with it or refer the patient to a higher level of care. So since 2019, it's over 32,000 alerts on the platform.
Oh my God. that people are at risk of self-harm?
Self-harm, right. We're running it, of course, with the teens, and, we've had alerts that we've been able to intervene on. It's a proprietary algorithm. We don't think anybody else has it. We are also looking at alerts right now for harm, both homicidal tendencies. We're also looking at eating disorders. We're also looking at abuse. So what we're doing is using the engine.
Abuse, someone who is being abused?
Being abused.
Yeah.
Yes. There is more than you want to know about
domestic violence.
Domestic violence, referrals we've had to make to Child Protective Services, et cetera. Yeah, it's more than you want to know. But what we're doing is we're finding it, right? So the power, what you want to do is give the therapist the ability to make decisions. What we don't do, which I'm a huge believer in, is I'm not going to tell a therapist how to give care. What I'm going to do is give them the alerts and let them decide. And we don't just, we don't do AI bots or anything like that. We will not do AI therapy. So this is a support mechanism.
Are some people doing that?
Yes. Yeah, there are some people out there who are doing AI supported therapy.
Like Chat GPT stuff?
Yes.
Yeah.
Yes. So that's what we're doing on the teen side.
And so you said you've had 32,000
alerts since 2019.
Is there any way to quantify how many suicides you've intervened in, or potential suicides?
So that's an amazing question, and the answer is no, because we don't really know. We're, again, HIPAA compliant. People could leave therapy. We don't know where they're. We can't follow up and say, hey, what happened to this person? So we don't know the answer. We've tried to use some surrogate analysis, but we've been unable to determine whether or not how many people have gone on.
What about the effectiveness of working with these teens in the New York City public schools? You say you're going to do another program in Seattle, right?
Yes.
Is there any way of knowing the efficacy of Talkspace therapy for these kids? How do you measure if it's working, and what kind of feedback have you gotten?
So the program for New York City is for all teenagers who live in New York. It's not just public schools. So whether it's parochial schools or yeshivas or charter schools, any kid 13 to 17 has access. And that was the decision. That's the mayor decided that when he did the program, that's how he wanted it. He wanted to make it available to everybody. So we have 1 year into the New York City program. We have 1 year data. We've had almost 70% improvement in terms of clinical outcome. I think I talked about we're reaching kids where they are, which is in all sorts of communities. What's interesting is the top diagnoses or problem is actually being a better self. Second is relationships, and then it drops off to anxiety/depression. Bullying relatively low, which was a surprise to us. But the relationship thing and being a better self is really important. And we had done a bunch of focus groups before we launched, and it was very clear the kids, I say, they want access, they want it immediately, and they want it, almost whenever they could get it. So we've basically solved that issue.
When you say relationship,
relationships with family or relationship with friends. In other words, they'll say, I have an issue with a friend. I have an issue with my parents. I have an issue with help me, talk me, the therapist, help me get through that. How do I deal with those kind of familial problems or other problems that they have? The being a better self just means they want to be better at who they are. They want to be more, self-aware.
It's really a whole fascinating area. And I think you're right. As a physician, if you see a need and you have the capacity to fill it, that must be incredibly gratifying.
Yes. On top of everything else, we're doing good. We're doing a lot of good, which makes, all of us feel, really good about what we're doing every day.
How do you increase awareness that this is out there? And let's say I'm like, oh, I really enjoyed talking to Dr. Cohen. Yeah. I want to be a part of Talkspace. I don't have a therapist. Actually, I don't have a therapist. And, I want to find a therapist. Do I go to an app? What do I do?
So there's multiple ways, but essentially you go on to Talkspace.com. For the teens, it's New York City Teen Space.
What about other teens across the nation? Is it available to them or not yet?
So it is it is through their parents' insurance.
Yeah.
So the difference is you have to go on.
That must be hard because sometimes
you don't want to go on.
Want to tell their parents.
Well, that's another interesting issue is parental consent. We do get parental consent. through the process. It's all part of the digital intake. We send an email to the parents. They mail us back their consent. There are exceptions. You can not have to get parents' consent. There is certain kids who are, by the court deemed independent. There are kids that are married. There are kids that have children. And then there are just kids that will come on and say, I don't want to tell my parents. And then what happens is they have a conversation with the therapist, and the therapist will make the ultimate decision with the child about whether or not they're at risk and whether they should tell their parents. So we have an entire consenting mechanism that's built in. So that's an important part of it. But most teens, if you get it through one of the programs, the reason it's so important that there's a program that pays for it is because what you don't want is to have a teenager say, okay, well, what's your parents' insurance? Go get their insurance card, fill out the information. As we said earlier, the number one barrier we know is cost, or having to identify costs. So sure, every teenager across the country has access, but those other teenagers have to go through their insurance, which is a barrier. It's always a barrier.
And I can't believe you don't have a shortage of therapists. I mean, I know you talk about the flex schedule and everything, but I mean, I've heard for a long time that it's just there aren't enough therapists for all the patients out there.
Yeah, and they're unfortunately referred to as ghost networks. So you've probably heard the term. No? Okay. So there's a term, it's called ghost networks for the payers, which means if you try and get a therapist, frequently if you find somebody and you check, they're not taking new patients, or it's a 3-month wait to get it.
Right.
Yes.
So how do you combat that?
Right now for us, it's not been an issue. Now, we do know that, quite honestly, the therapists mostly like being on the Talkspace platform. We've made it very easy for them. They just have to come on and do therapy. We do all the billing and collection and all the administrative work. And we educate them, and we provide a network for them. We provide other people for them to talk to. So it's not just that they're coming onto Talkspace, but they're becoming part of a very large community that helps them be better at what they do also. So
I always tell young people to go into therapy. Talk about a growth industry, right? Don't go into media. Become a therapist.
Right. Yeah. Sounds right. It sounds about right. So, but we are always recruiting.
Do you do group therapy?
No, we do peer-to-peer, which is, it's not really group, but it's peer-to-peer support. We also have launched, and we don't really do coaching. But would you ever get into group therapy, which is very effective? Yeah, we've talked about it, and like I like to talk about it, I like to stay in our lane. What I mean by that is there's so much need for what we have right now. I want to continue to focus the company on what we do best, which is what we're doing right now.
Do you do specialty? Do you have anyone who specializes, say, in cognitive behavioral therapy? Yeah,
no. Basically, every therapist does.
Yeah.
Because that's how they're licensed. Remember, all of our therapists are licensed. They're fully licensed to deliver therapy in the state that they're in, and each state has different rules and regs.
Have you tried Talkspace?
I have. Yeah. So.
I know that's kind of a personal question. Yeah. You don't have to necessarily answer that. But I mean, I would think as the CEO, you would want to test your product.
Yeah. So what I've done it actually twice to test the product and see what the therapists do and to try the intake. But yes, I've taken it to a certain point, but beyond that, it would be difficult for me to have one of my own therapists obviously take care of me.
And by the way, I mean, talk about a need, the medical community. Yeah. I mean, we saw during COVID the amount of burnout among medical professionals, nurses and doctors and people who work in hospitals was so high. So many people left the profession. Is that a population you're kind of reaching out to?
So right at the beginning when I first got there, Talkspace had done actually not only delivering therapy to healthcare workers, did a study. I think it was 600 plus healthcare workers. 35% of them were new to therapy, described an enormous need, watching what was going on.
By the way, can I just interject one thing, Jon? I thought during COVID that hospitals could have done a much better job of providing mental health support. I mean, I know everybody's hair was on fire, and I'm not being critical. I just think that was a huge vacuum at the time.
So we were providing it. We saw 50% improvement within 4 weeks.
Wow.
And there were a lot of healthcare workers who were texting and messaging their therapist and getting online to be able to, help them through. It was an enormously, as you said, difficult time for healthcare providers. I mean, we were, because I'm here, we were at almost ground zero for COVID in the Northeast at the beginning.
I remember.
Yeah, me too.
Is there anything you'd say to people who are still reticent about getting mental health care, or the word therapy kind of still freaks them out a bit?
The message is to try it. It's very easy. It's very affordable. Is to try it and see if it makes a difference in your life. I would say to parents to encourage their kids if there's an issue. There's still a stigma in certain populations for parents who don't want to talk about this with their kids, and I would encourage parents to also have their kids sign up.
That's one interesting thing that I've learned recently, that I think a lot of parents, with the number of kids who have suicidal ideation, I think for so long parents felt like they shouldn't talk about it or bring it up. Yeah. But my understanding is that it's okay to say to a child, do you feel like harming yourself? Do you think about hurting yourself? That's okay.
I certainly would encourage it, 100%. I mean, I think any conversation is good. Yeah, there's kids that just never talk to their parents. Or parents
and also you're afraid you're going to put the idea in their head.
Yeah, well, let me tell you, if you don't, they have plenty of access where it's going to go in their head. I mean, the amount of, unfortunately, on the social media stuff, whatever platform you're on, not criticizing any particular platform, there's all of these things out there relative to putting thoughts into kids' heads that you don't want them. And that's, again, why the whole issue right now is about how you regulate social media, how you know what's appropriate, how do you prevent it, how do you alert kids. It's an enormous problem. It's the Surgeon General said it's the greatest threat to children's lives is social media. It's greater than cigarette smoking right now.
And I'm happy to hear so many schools are starting to say no phones during school hours.
I couldn't agree with you more. Taking them away. I couldn't agree with you more. We've had the discussion. They say, well, you're providing therapy on your phone. Do you have an issue? I said, absolutely not. Take the phones away. During school hours, 100%. They could get therapy after hours. They don't need to have their phone, during school. It's a huge issue.
Dr. Jon Cohen, a.k.a. John.
Yes.
Since I can call you that.
Yes.
Thank you so much for being on Next Question.
My pleasure. Thank you for the privilege, actually. And it really is a privilege and honor to sit here and talk to you about this and to get the word out. So thank you for doing this, actually. Yeah.